Welcome to another episode of Uncovering Bailey in Love with Snazzy Surgeon.
Great to be here.
Today we're tackling a topic fundamental to our practice, breast carcinoma. As surgeons, a robust understanding of its global impact and the nuances of its risk factors is absolutely essential for how we approach our patients every day.
Absolutely. When you step back and look at the sheer scale, it's quite sobering. In 2020, we're talking about an estimated 2.3 million new diagnoses of breast cancer in women worldwide.
Wow.
That single malignancy accounts for around 25% of all cancers diagnosed in women. Just think about that. 1 in 4.
And the geographical variation in those numbers is really striking, isn't it? You see incidence rates as low as, 27 per 100,000 women in regions like Middle Africa and East Asia.
That's right.
Then you contrast that with North America, where the rate jumps to 92 per 100,000 in the same year. What do you make of such a dramatic difference?
Well, it speaks to a complex interplay, I think. You've got genetic predispositions within populations, environmental factors that might be more prevalent in certain regions, and of course, significant variations in lifestyle and access to screening and healthcare. Big differences there.
Yeah.
Then you look at Western Europe, where about 1 in 9 women will develop breast cancer in their lifetime, and sadly, this contributes to 3 to 5% of all female deaths.
It's a statistic that really underscores the gravity of the disease, particularly in high-resource settings. But the picture is even more concerning in resource-limited countries, right?
Oh, definitely. There, while the incidence might be lower, maybe around 1 in 28 women developing it, the mortality rate is alarmingly high.
How high?
Almost a 1-to-2 ratio of deaths to diagnoses.
Yeah.
It's really stark.
That really brings the challenges of access to care into sharp focus. Early detection, treatment.
It certainly does. Early detection and timely effective treatment make all the difference. But for our discussion today, let's really drill down into those risk factors. Understanding what elevates a patient's risk is fundamental to our assessment and management strategies.
Okay.
It's helpful, as you mentioned, to think about them in 2 broad categories. Those factors that individuals might have some control over, the modifiable ones,
Right.
and those they don't, the non-modifiable aspects. Let's start with what we can potentially influence. Obesity in postmenopausal women immediately comes to mind.
Absolutely. The data quite clearly indicates an increased risk there. For postmenopausal women with a BMI over 30, we're looking at a relative risk of around 1.29.
Yeah, almost 1.3.
It's a crucial point to address when we're counseling our patients about overall health and well-being after menopause,
Definitely. And then we have the complexities surrounding parity and the age at which a woman has her first child. We see an elevated risk in women who have never given birth.
Nulliparous women.
Right. Or those who have their first pregnancy after the age of 35. It makes you think about the prolonged exposure of breast tissue to unopposed estrogen in those scenarios.
Exactly. And it's interesting to consider the flip side, that early childbirth, particularly before the age of 20, is associated with a lower risk. It really underscores how the timing and hormonal shifts related to pregnancy can impact long-term breast health.
It does.
Following on that, breastfeeding offers a notable protective effect.
Yes, and the longer the duration, the greater the benefit seems to be. Over 12 months of breastfeeding provides more significant protection than shorter periods.
So why is that?
Well, the thinking is the cyclical hormonal changes and the differentiation of breast tissue during lactation. They're thought to contribute to this. It's another important aspect to discuss, especially, in the context of maternal and infant health.
Makes sense. Then we have hormone replacement therapy. This is always a nuanced conversation, isn't it?
It is. The data suggests an increased relative risk of about 1.2 with more than 10 years of HRT use, particularly with estrogen-containing therapies.
So over 10 years is the key threshold there.
Seems to be. It highlights the importance of weighing the benefits for menopausal symptoms against the potential long-term risks to breast health. It's a careful balance.
Moving to lifestyle factors, tobacco use shows a clear dose-response relationship.
Yeah, quite clear. We see a relative risk of around 1.145 for those smoking 25 or more cigarettes a day. Heavy smokers.
And duration matters too.
It does. Even a longer duration of smoking, say 20 years or more, carries a slightly elevated risk, around 1.07. It all points to cumulative cellular damage over time, really.
It reinforces the broader health benefits of smoking cessation then. And alcohol consumption is another modifiable factor where we see a gradient of risk.
Right, another dose-response situation. Light drinking, less than 1 drink a day, has a relatively small increased risk, around 1.05.
Pretty small, yeah.
But when you get into moderate consumption, say 3 to 4 drinks a day, that relative risk jumps to 1.32.
Okay, noticeably higher.
And for heavy drinkers, those consuming more than 4 drinks daily, it's even higher at 1.46. It's important to contextualize these population-level risks when advising individual patients, though.
Absolutely. While a small relative increase at an individual level might not seem dramatic, at a population level, even light to moderate alcohol consumption can contribute to a significant number of breast cancer cases.
Precisely. Lastly, in the modifiable category, we have radiation exposure.
And that's a factor that carries a really significant elevated risk, a relative risk of around 6. That's huge.
It is. It's something we always need to carefully consider in patients with a history of prior radiation therapy to the chest area, say for lymphoma, weighing the necessity of that prior treatment against the subsequent increased risk.
Right. Careful consideration. Okay, so now let's shift our focus to the non-modifiable risk factors, those aspects of a patient's history and biology that we can't change. Age is obviously a primary one.
The primary one, probably. The risk of breast cancer increases steadily as women get older. It's just a clear trend.
We see that clearly in our clinical experience. The median age at presentation in Western countries is around 60 years. But it's crucial to remember that in low and middle-income nations, that median age is significantly younger.
Much younger, around 48 years in places like India. This likely reflects differences in screening programs and perhaps earlier exposure to certain risk factors, or maybe even different tumor biology in some cases.
Interesting point. And of course, sex is a major determinant. While we do see breast cancer in
Heck, so
men,
really?
it's overwhelmingly a disease affecting women, with only about 0.5 to 1% of cases occurring in males.
Tiny fraction. Ethnicity also plays a role. We observe higher risk in certain populations.
Such as?
While American white women overall, African American women under the age of 45 specifically have a higher risk of more aggressive cancers, and individuals of Ashkenazi, Jewish, and Parsi descent in India.
Right. There are likely genetic and potentially environmental factors contributing to these differences, aren't there?
Absolutely. And family history is a well-established risk factor that we always meticulously explore. It's critical. The risk increases with the number of affected first-degree relatives.
How much does it increase?
If a woman has one first-degree relative, mother, sister, daughter with breast cancer, her relative risk is around 2, double the baseline.
And that jumps to a relative risk of 3 if there are 2 first-degree relatives affected.
Yeah.
It really highlights the importance of a detailed family history in our initial risk assessment and in guiding decisions about further evaluation like genetic testing.
Which leads us directly to genetic predisposition. We know that somewhere between 5 and 10% of breast cancers have a hereditary component. Not the majority, but a significant subset.
And the BRCA1 and BRCA2 gene mutations. They're the big ones.
They account for a significant proportion of those hereditary cases, approximately 70%. These genes play a crucial role in DNA repair, so mutations can lead to increased susceptibility to cancer development. Genetic testing has become an increasingly vital tool for identifying these high-risk individuals.
Definitely. Then we have factors related to a woman's reproductive history that are non-modifiable, such as early menarche, starting periods early.
Yes. For every year earlier than age 12 that menstruation begins, there's about a 5% increase in risk. For menarche before age 11, the relative risk is around 1.19.
So again, it suggests that earlier and longer lifetime exposure to estrogen plays a role.
Exactly. Similarly, late menopause, defined as after age 55, also increases risk. For every year later than 45, there's about a 3% increase, with a relative risk of 1.12 for menopause at 55 compared to 45.
So a longer reproductive window, more estrogen exposure overall.
That seems to be the common thread. Finally, we need to consider the presence of high-risk breast lesions identified on biopsy. Certain benign proliferative conditions carry an increased risk of subsequent carcinoma. These aren't cancer, but they're warning signs.
Right, like proliferative conditions without atypia, such as usual ductal hyperplasia.
Yes, those have a relative risk in the range of 1.8 to 2, so almost double. Then we have conditions like complex fibroadenomas and papillomatosis.
What's the risk there?
They both carry a relative risk of around 3 times the baseline risk.
Okay. And when we see proliferative diseases with atypia, such as atypical ductal or lobular hyperplasia, the risk increases further.
Oh yes, significantly. There we're looking at a relative risk of 4 to 5. These are lesions that definitely warrant closer surveillance and serious consideration of risk-reducing strategies, like chemoprevention.
And perhaps carrying the highest risk among these pre-invasive lesions is lobular carcinoma in situ, LCIS.
Correct. LCIS carries a relative risk estimated to be between 8 and 10, a very substantial increase. Recognizing these high-risk lesions on pathology is absolutely critical, as it significantly impacts our management and surveillance protocols.
We've certainly covered a significant amount of ground today, haven't we? From understanding the global burden of this disease to really dissecting the wide array of risk factors involved in breast carcinoma.
Indeed. And the varying relative risks associated with the modifiable factors really underscore the importance of the lifestyle advice and risk reduction strategies we discuss with our patients every day.
Absolutely. Yeah. Even seemingly small changes at an individual level can have a significant impact at a population level, as we discussed with alcohol.
Exactly. And having a firm grasp on the non-modifiable risk factors allows us to better stratify risk, identify those patients who might benefit from more intensive screening, maybe MRI screening or preventative measures, and ultimately tailor our management strategies more effectively.
It's all about personalized medicine, isn't it?
Increasingly so.
Hmm.
It's also important, I think, to keep in mind those stark global disparities in incidence and mortality we mentioned earlier. It serves as a constant reminder of the ongoing need for improved access to early detection and treatment worldwide. A major challenge.
Absolutely. It really prompts us to consider, in our own practices, which modifiable risk factors we address most frequently and maybe how we can continually refine our communication strategies to ensure our patients understand and, crucially, act on this information.
That's the key, isn't it? Effective communication.
Indeed. Well, that's all the time we have for this deep dive.
It went quickly.
Thank you for listening to our podcast. See you in the next episode.